Let's move on to the new chapter on Cushing syndrome. In the previous section, we have discussed in detail on pheochromocytoma and paraganglioma, where pheochromocytoma is primarily a disorder of adrenal medulla. In this particular section, we are going to shift our focus towards the adrenal cortex, and one of the very important disorders of the adrenal cortex is Cushing syndrome, where you are going to get questions in and out in any exam in the world. So please pay proper attention to this video. In this particular section, we have discussed in detail on etiology, pathogenesis, clinical features, workup, as well as the management of Cushing syndrome. So without wasting much time, let us move to the basics of Cushing syndrome and start with the basics. You know, the axis is going to start with the hypothalamus, which is the master controller of the master gland, that is the pituitary, where it controls the corticotroph of the pituitary through two compounds. One is the CRH, called as corticotropin releasing hormone, or otherwise referred to as corticotropin releasing factor, which is going to work on the CRH receptor to produce ACTH. Second molecule by which your corticotrophs are regulated is the vasopressin, otherwise referred to as ADH, where it's going to work on the V1B receptor, previously referred to as V3 receptors, where stimulation of any one of these receptors is going to result in production of ACTH by the corticotrophs of the anterior pituitary. This ACTH is not produced as ACTH. We know it is produced as a larger molecule called POMC, that's called pre-opiomelanocortin, which is further processed by an enzyme called proconvertase 1 to produce three different molecules. One is the MSH, alpha, beta, and gamma MSH, which will subsequently work on melanocortin 4 receptor, where it's going to produce multitude of effects. In the periphery, stimulation of this MC4 receptor on the melanocytes is going to result in melanin production and pigmentation. And in the brain, this MC4 receptor is also important for your appetite and hunger-related pathways, which we'll be discussing in detail in the obesity section. Then second compound that is released by action of proconvertase 1 on POMC is ACTH, where it's going to work on the melanocortin 2 receptor on the adrenal cortex, whose effects we'll be seeing subsequently. And third one is the beta endorphin that is cleaved. All these things we have seen in the basics videos itself. So this endorphin will work on the endorphin receptor, where it is very important for the pain controlling pathways. Now this ACTH is going to work on the adrenal cortex, where it's going to have trophic effects on the adrenal cortex. ACTH has stimulatory effects on glomerulus fasciculata as well as reticularis, but when you consider the steroidogenic pathways, ACTH will be effective in the zona glomerulosa only up to the level of production of 11-DOC. Beyond 11-DOC, ACTH cannot produce any stimulation of the steroidogenic pathways to produce aldosterone, because the production of aldosterone from 11-DOC is largely under the control of aldosterone synthase, which in turn is under the control of renin-angiotensin axis. So whenever you have a ACTH stimulation on the adrenal cortex, you are going to produce cortisol, and you are also going to result in production of DHAS, which is a major adrenal androgen. This cortisol is the most important compound that gives feedback to the hypothalamus and the pituitary, which means whenever you have a high cortisol, you're going to have a low ACTH and CRH production. Whenever you have a low cortisol, you're going to have increased CRH and ACTH production from the hypothalamus and the pituitary respectively. Whereas aldosterone does not give feedback to the hypothalamus and the pituitary, and DHAs has very, very little feedback effect on the pituitary and the hypothalamus. So the major hormone that gives feedback to the hypothalamus and the pituitary is cortisol. So whenever you have a high cortisol, this is what we refer to as a hypercortisolism or a Cushing state. So whenever you have a high cortisol, we call it as hypercortisolism, or we can vaguely call it as a Cushing state or a Cushing syndrome. So this hypercortisolism can be divided into two. One is called a pathologic hypercortisolism, and second one is physiologic hypercortisolism. This physiologic hypercortisolism is also referred to as pseudo-Cushing's, where I personally don't like the name, but still it should not be called as Cushing's, but only pathologic hypercortisolism should be called as a Cushing syndrome. But this physiological hypercortisolism has a tag name called pseudo-Cushing states. And this pathologic hypercortisolism or any pathologic glucocorticoid excess is what we term as Cushing syndrome or a true Cushing syndrome or true Cushing state, which can be further divided into two. One is called a exogenous Cushing's, where the problem will be due to exogenously administered glucocorticoids. And second one is endogenous Cushing syndrome, where this excess cortisol will be due to some endogenous problems. So remember, this exogenous Cushing syndrome is the most common cause of Cushing syndrome by default. Very, very common. Exogenous Cushing syndrome due to use of exogenous glucocorticoids. In the current era, this is going to be the most common cause of Cushing syndrome, obviously. So what are the risk factors for developing this exogenous Cushing syndrome? So what are the risk factors, or what are the risks that will increase the development of exogenous Cushing syndrome? Number one is the dose of the steroid that you're going to use. Especially if you are using more than 20 milligram per meter square per day steroid, which is prednisolone equivalent dose. So always we compare with prednisolone, and when we take this much high dose of steroid, which is a prednisolone equivalent, especially for more than 2 to 3 weeks, you are likely to develop Cushing syndrome. What are the conditions that reduce the risk? Obviously, whenever you give an alternative day dosing, it is having slightly reduced risk of developing Cushing syndrome compared to that of daily dosing. Similarly, nighttime dosing has a little increased risk compared to the morning dose. So that's why many people do give in the morning this exogenous glucocorticoids. Similarly, this exogenous steroids causing Cushing syndrome is more with systemic steroids compared to that of topical steroids. So take-home point is the fact that even topical steroids and local steroids, other forms of local steroids like inhaled steroids also can result in production of Cushing syndrome. That's a very important point. Even though the risk is less, but still it is on. This inhaled corticosteroids, many people don't know the fact that whatever steroid dose you give, 20 to 40% is actually absorbed into the systemic circulation. This inhaled steroids causing Cushing states is especially true whenever you are thinking about a patient who's having uncontrolled bronchial asthma. So because most of the times bronchial asthma patients who are uncontrolled will be receiving high dose inhaled corticosteroids that increase the risk of them developing Cushing syndrome due to this inhaled corticosteroids. But COPD patients possible, but usually high dose of inhaled corticosteroids we don't use in COPD because, as I told you in the pulmonary section videos itself, steroids are not that effective for COPD related inflammation than it is for bronchial asthma inflammation. So anyways, fine. So inhaled corticosteroids is also associated with development of Cushing states. Topical steroids can cause Cushing syndrome, but certain things will still increase the risk of developing Cushing syndrome with relation to topical steroids. One, if you are applying these topical steroids in inflamed areas, absorption will be more. Added on to that, if you are closing the dressing after applying a steroid cream on the inflamed area, so which means closed dressings will further increase the risk of development of Cushing syndrome with the topical steroid. So which means the local steroids, topical, inhaled, can also cause Cushing syndrome. That's the important take-home point. Similarly, long-acting agents like dexamethasone, synthetic steroids, have more risk of developing Cushing syndrome compared to short-acting ones like hydrocortisone. So this also should be kept in mind. Dexa will not bind to CBG that much, and it will be having a much higher half-life, and it's a very powerful glucocorticoid. So that is the reason why dexamethasone is associated with high risk of developing Cushing syndrome. And what is the mechanism and what will be the picture that you will see in a exogenous steroid use? So obviously you have a hypothalamic pituitary axis where you are going to generate ACTH, and you have an adrenal gland here. Adrenal gland is going to produce cortisol, and this cortisol is the one that is going to give feedback to the hypothalamus and the pituitary. But in a patient who is receiving exogenous glucocorticoids, this exogenous steroid is going to bind to the glucocorticoid receptor in the pituitary and the hypothalamus, and they're going to suppress the hypothalamic production of CRH and pituitary production of ACTH. So they're going to produce strong inhibition. So once the ACTH is lowered, your cortisol levels will drop considerably, but the functions will be maintained because you are giving exogenous glucocorticoids in this scenario. But atrophy of this CRH and ACTH related pathways will happen if you give this exogenous glucocorticoids for a period of 2 to 6 weeks. That's why that usage of more than 2 to 3 weeks is very important, because beyond 2 to 3 weeks, which means usually by 2 to 6 weeks time, the CRH ACTH pathway will not be properly functional. Similarly, when you are giving exogenous glucocorticoids for more than 6 weeks, which means your ACTH will be persistently low for more than 6 weeks, your trophic effects of ACTH on the adrenal cortex will be decreased for a considerable period of time, which means the adrenal cortex will go for atrophy, especially this zona fasciculata is going to go for atrophy, which is highly dependent on ACTH. So to recover from this atrophic pathways, it takes some time. So that is the reason why whenever you are giving large dose of exogenous steroids, especially for a longer duration of time, it is always better to taper the dose rather than stopping the dose abruptly. If you stop the dose abruptly, these pathways will still be non-functional for a variable period of time, which means they may not recover completely and you might end up with the adrenal insufficiency. If possible, in worst case scenarios, you can end up with the adrenal crisis also. That is why whenever you give a long dose steroid for long acting steroid, especially for a longer duration of time, so it's always better to stop the steroid slowly rather than stopping abruptly. That's a very important point. So what will be the picture? You will be seeing low ACTH and obviously you will be seeing low cortisol as well. This is the scenario in most of the conditions, but if you use hydrocortisone, this cortisol levels may be a little variable, because hydrocortisone is nothing but a pharmacological cortisol. You just take cortisol, purify it and give in tablet form, that is hydrocortisone, or injection form. So whenever you give hydrocortisone, your cortisol levels may be a little higher also, maybe in the normal range also, because it is going to interfere with the cortisol assays. That is the reason why whenever you're using suppression test for diagnosis of Cushing's, you use dexamethasone suppression test. Why? Because the same principle you are going to use it for dexamethasone suppression test, where normal patients, obviously when you give a dexamethasone, they are going to reduce ACTH and they are going to reduce the cortisol. So next day after giving dexamethasone, if you see, they will be having a low cortisol. So that is suggestive of a normal axis in the body, that is normal hypothalamic, pituitary and adrenal axis. So that is considered to be a normal patient. But patients with Cushing's, if there is a problem in the axis, either the hypothalamus or the pituitary or the adrenal gland will not respond to this suppression by the exogenous glucocorticoids, so cortisol levels will be persistently high. So that is the basic diagnostic point that you have to know why we use this dexamethasone suppression test. But many students do ask me, why do we use dexamethasone and why can't we use hydrocortisone suppression test? Hydrocortisone is also a good glucocorticoid if it's given in appropriate doses. Why we can't use that? The problem is next day you are going to measure serum cortisol. As I told you, next day you're going to measure the serum cortisol after giving the previous day dexamethasone. So if you give hydrocortisone instead, when you measure the serum cortisol next day, it is going to interfere with your assays. But dexamethasone will not interfere with the cortisol-based assays. That is the reason why you prefer dexamethasone. But dexamethasone, to find out the levels, we have separate assays for dexamethasone. That's fine. But it is not going to interfere with the cortisol-based assays. So that is the reason for this suppression test-based purposes, dexamethasone is the best drug. Fine. With exogenous steroids, you will be usually encountering low ACTH and low cortisol, but this cortisol levels are a little variable, I told you, especially when you use hydrocortisone, which will definitely interfere with the cortisol-based assays. And methylprednisolone and prednisolone, to an extent, they might interfere, but not completely like hydrocortisone. But dexamethasone will not even interfere with the cortisol-based assays. All right. Suppose a patient with Cushing's syndrome features, patient is having a Cushing's features, plus they are coming with adrenal insufficiency features also. This is a very common scenario, in fact. What will you interpret? So what you will be interpreting here is very simple. The patient has taken exogenous steroids for a long time, and he or she has stopped this exogenous steroids suddenly due to maybe some illness or something else where he couldn't take the exogenous steroids properly. That is the reason why they are suddenly coming with adrenal insufficiency, because I told you the axis to recover, it will take some time. So how to stop the steroids? I already discussed, but still we'll be discussing in detail in the next chapter on adrenal insufficiency. But I mean, right now you have to understand this loop, that is more than enough. So basically speaking, the most common cause of Cushing syndrome in the world is use of exogenous glucocorticoids, otherwise referred to as exogenous Cushing's. Endogenous Cushing's may be due to many reasons. One, it could be due to excess ACTH, causing excessive cortisol. This kind of endogenous Cushing syndrome, we tend to call it as ACTH dependent Cushing syndrome. Clear? Which means the high cortisol here is a secondary effect to a primary effect called elevated ACTH. So elevated ACTH can be coming from many sources. It could be a pituitary source, or it could be a ectopic source like some ectopic cancers also, which can cause this excessive ACTH. So this is ACTH dependent. Or you can have a high cortisol independently as a primary entity, where usually the adrenal will be the problem. So because of the high cortisol giving feedback to the pituitary and hypothalamus, here pituitary and hypothalamus are normal, so they will be having suppression of ACTH, but here because the adrenal problem, they will be autonomously producing high cortisol. So this kind of high cortisol with low ACTH, we call it as ACTH independent Cushing's. Usual reason will be in the adrenal gland, but there are some minority of the cases where receptor defects have been proven to produce this ACTH independent Cushing syndrome. So we'll be discussing in detail about the causes in some time. So what about the pseudo Cushing's? Pseudo Cushing's is nothing but a physiologic hypercortisolism. Remember, these are major confounders for Cushing syndrome diagnosis, because many patients with pseudo Cushing's may mimic an actual Cushing syndrome or a pathologic Cushing's. So that is why it's better to do some test to differentiate if you have suspicion, or you can wait for some time and you can start evaluating for Cushing syndrome once the illness is over. So what are the illnesses that can cause physiologic hypercortisolism, and what are the illnesses in special that can mimic a true Cushing, but they are actually producing physiologic hypercortisolism? So I'm going to split the pseudo Cushing's and physiologic hypercortisolism into two entities. One are the conditions that can produce physiologic hypercortisolism, but have some or few features of pathologic Cushing's. Some or few features of pathologic Cushing's. What are those? First one is the severe obesity itself, which can have high cortisol, because obesity itself is a confounding factor for the diagnosis of Cushing syndrome. Second one is severe insulin resistance, especially conditions like uncontrolled diabetes mellitus and PCOS. These conditions also can have high cortisol and can mimic a Cushingoid state, but they are physiologic hypercortisolism only. These are not pathologic Cushing's. And third, patients who are pregnant. Pregnancy is a state of high cortisol because of stress, obviously, and they have weight gain in pregnancy, also may have hypertension, so it is a major confounding factor for the diagnosis of true Cushing's. And pregnant patients may have pathologic true Cushing's also, but how to diagnose that is beyond the scope of the current discussion. If it's possible, I'll discuss at the end. Apart from that, there are some causes which are even more important, like chronic alcoholism, which can mimic Cushingoid state and can have cortisol excess, and severe depression. And this depression is very, very important, because whenever you take a disease that is basic entity for a definition of a pseudo Cushing, that is depression. We have a lot of research articles which tell you how to differentiate between a pseudo Cushing and a true Cushing. So for that, the first disease they'll be mentioning is depression. They'll be comparing with the depressed patients only who are likely to have pseudo Cushing's. And it's very important to understand that Cushing's itself can produce depression due to steroid excess, and depression itself can result in cortisol excess, causing a pseudo Cushing-like appearance. So you have to be very careful about that, because depressed patients give rise to a very big diagnostic nightmare in diagnosing Cushing syndrome in these patients. And there are some conditions which may have hypercortisolism and physiologic hypercortisolism, but they may not have any clinical features that are suggestive of a Cushing syndrome. So what are these conditions which have physiologic hypercortisolism, but they do not have any clinical features of Cushing syndrome? First one is extreme stress. For example, a critical illness. They will have high cortisol, but they do not have any features that are suggestive of Cushingoid state. Second one, whenever you have a extreme exertion, chronic intense exercise, may result in high cortisol, but they may not have features of Cushing syndrome. And patients who are having severe anorexia and malnutrition, like patients with anorexia nervosa, they may have high cortisol, but they may not have features that are suggestive of Cushing syndrome. They'll be lean and they don't have features that are suggestive of Cushing syndrome at all. And patients who are having hypothalamic amenorrhea, we have discussed about this in a little bit of detail in the previous chapters itself. And patients who are having high cortisol binding globulin. This is an assay problem. So since our assays measure the total cortisol, when you order a serum cortisol test, the serum cortisol will appear as if it's increased because of the elevation of the cortisol binding globulin. Elevation of cortisol binding globulin usually happens in the setting of pregnancy or estrogen exposure. Whenever the patient is receiving oral contraceptive pills, this becomes very important. So here the urinary free cortisol will be anyway normal only. That will clearly exclude a pathologic Cushing syndrome, but still you might have a elevated cortisol. Similarly, a patient who is having a very interesting disorder called cortisol resistance or glucocorticoid receptor resistance. I think I have discussed about this topic in the hyperandrogenism chapter itself, but I have not discussed in detail. It's a very interesting one. Let me tell you what is the problem here. Here the problem is in NR3C1 receptor. So in the NR3C1 gene, this NR3C1 gene is the one that is responsible for production of this glucocorticoid receptor. So this glucocorticoid receptor is the one that is important for receiving the feedback from the cortisol. At the same time, it is the one that translates the cortisol effects in the peripheral organs as well. So we know that ACTH is going to stimulate the adrenal glands to produce cortisol. This cortisol is going to give feedback to the hypothalamus and the pituitary, and they are going to produce effects in the periphery also. Remember, this feedback as well as effect is based on the glucocorticoid receptor. Clear? So whenever the patient is having problems in this glucocorticoid receptor, the effects will not be produced properly, which means patients will be consistently complaining of fatigue and lethargy. And at the same time, the hypothalamus and pituitary also cannot receive a proper feedback, which means they will think as if there is no cortisol in the periphery. And since these receptors are not functioning properly, they will start increasing the ACTH production because they think there is no cortisol outside. This increased ACTH can result in even hyperpigmentation. And at the same time, this will act on the MC2 receptor, which are normal. Here, there is no problem. Melanocortin-2 receptor, which are nothing but ACTH receptors, they will be stimulating normally on them and they will be producing excessive cortisol. They don't only have excessive cortisol, they might even have excessive DHAS for that matter, and some patients they might have even excessive 11-DOC also, depending on how much ACTH is elevated. But patients will have this excessive cortisol, but what you will see is a thin patient with fatigue and lethargy. So this itself should give you a clue about glucocorticoid receptor problem or cortisol resistance, which is otherwise referred to as Krauss syndrome. So this is a very interesting disorder, clear? So which is going to produce probably a physiological hypercortisolism with no features of Cushing syndrome in the first place. So now we know that Cushing syndrome is pathologic or physiologic hypercortisolism. So where pathologic is our main concern, physiologic is not a problem, but still even though we have to rule out in our clinical practice. And pathologic Cushing's can be due to exogenous Cushing's or endogenous Cushing's, where exogenous is the most common. Endogenous is not that common, but in exam you will be getting questions only on endogenous Cushing's. Among the endogenous Cushing's, you have ACTH dependent cause and ACTH independent causes. If they ask you among these two which is the common, you have to answer ACTH dependent causes. Among the ACTH dependent causes, whether pituitary ectopic, which is more common, your pituitary causing this Cushing syndrome is what is the most common cause of endogenous Cushing syndrome. So now let us go and discuss on the endogenous causes of Cushing syndrome in detail. So endogenous causes of Cushing syndrome, as I told you before, it can be ACTH dependent, where you'll have a high ACTH. Because of the high ACTH, you will have a high cortisol. So this is otherwise referred to as ACTH dependent. So I can write ACTH dependent means you have a high ACTH due to some reason. Because of that, you will have a excessive cortisol, which means the primary problem here is high ACTH. That is the main problem. high cortisol is the effect of this high ACTH. Okay, so let me put a line of demarcation here between ACTH dependent and ACTH independent causes. As I told you, the number one cause is going to be the pituitary cause with regards to ACTH dependent. And remember, this is the most common cause of endogenous Cushing syndrome overall, where it will be contributing to 65% of the case of Cushing syndrome overall. We are talking about endogenous Cushing's. It has a slight female preponderance compared to that of the males. Remember, this is very important because our another cause of ACTH dependent Cushing, that is ectopic cause, will not be having any sex predilection. So that's why I'm telling this point. Females are having a little slight preponderance for developing this pituitary related ACTH dependent Cushing syndrome compared to males. What are the pituitary related causes? You can split into two. One, it could be a pituitary hyperplasia or it could be a pituitary adenoma, where adenoma tends to be the most common. Adenoma means you are developing a corticotroph adenoma that only can produce excessive ACTH. This corticotroph adenoma causing Cushing syndrome is what we refer to as Cushing's disease. Very, very important point. Cortisol, ACTH producing pituitary adenoma causing Cushing syndrome is what we refer to as Cushing's disease. So this pituitary adenoma producing ACTH can be either a microadenoma or a macroadenoma. We know microadenoma means those pituitary adenomas that are less than 1 centimeter in size, and macroadenomas means those pituitary adenomas that are more than 1 centimeter in size. If they ask you which adenomas are common with respect to Cushing syndrome, the microadenomas are more common compared to macroadenomas. More than 90% of the case of pituitary adenomas will be microadenomas, especially with regards to the Cushing syndrome and Cushing's disease. Macroadenomas will be less common. Why? Because Cushing syndrome is one condition which is going to produce overt clinical features, symptoms and signs, which means they will be presenting much early. That is the reason they will be presenting at a earlier stage of the tumor itself. That is also one reason why non-functioning adenomas generally tend to present at a very large tumor size stage. Why? Because they don't produce any clinical effects. So the patient will tend to present at a very later stage itself, which we have discussed already in the pituitary basics. So what will be the features of this pituitary related Cushing syndrome or Cushing's disease to be specific? So number one, they'll be having a gradual progression and they'll be having all the typical and classical signs and symptoms of Cushing syndrome, which I'm going to talk about in some time. And number three, it's very, very important to talk about the dexamethasone suppression test also, which we'll be discussing in detail later on. We have two types of dexamethasone suppression test. One is called a low-dose dexamethasone suppression test called as LDST. Second one is a high-dose dexamethasone suppression test called as HDST. What will be the effect of dexamethasone suppression test on this pituitary adenoma? Usually they won't respond to low-dose dexamethasone suppression test, which means there won't be any suppression of the cortisol. But they may respond to this high-dose dexamethasone suppression test and they may produce fall in the ACTH and cortisol levels with high dose of dexamethasone. And this is a very, very important point because other Cushing syndromes, endogenous causes, will not respond to this high-dose dexamethasone also. But only this pituitary adenoma or pituitary-related causes only will respond to high-dose dexamethasone and they will cause a suppression in the ACTH and the cortisol. Very, very important point. Now let us move on to the ectopic cause, ectopic Cushing's. Ectopic is also an ACTH dependent cause only because they're going to produce excessive ACTH, but here it's not the pituitary that produces, it's going to be some cancer that's going to produce this excessive ACTH as a part of paraneoplastic syndrome. There are many cancers which can produce excessive ACTH. Many cancers will be of neuroendocrine origin only because those only can produce some similar substances, the neuroendocrine substances. Like for example, a small cell lung cancer, which is the most important for our exams, or it could be pheochromocytoma, but very rare. Pheochromocytoma producing PTH-related peptide causing hypercalcemia is relatively common compared to ACTH production. Or it can happen with a pancreatic neuroendocrine neoplasm, NEN, or it can even happen with certain cancers like carcinoid tumors or medullary thyroid cancers. All these are spectrum of neuroendocrine tumors only. Or some pediatric tumors like neuroblastoma and Ewing sarcoma also can cause this ectopic Cushing syndrome, producing ectopic ACTH. So there are some clinical characteristics of this ectopic ACTH causing Cushing syndrome. Obviously, it's ACTH dependent. You will have high ACTH and high cortisol. There's no doubt about that. But the clinical course will be extremely rapid. That's the most important point. Very, very rapid course. And at the same time, they'll be having atypical features, or they will not be having classical features of Cushing syndrome. There will be paucity of classical findings. Why? Because it's so rapid that they won't have time to develop this obesity, that purple striae and all. So it will be that rapid. That is the reason why it will be fast, and they may not have that typical and classical features of Cushing syndrome that you see in other patients. Number 3, they might have hypokalemia and metabolic alkalosis. Remember, any Cushing syndrome can produce hypokalemia and metabolic alkalosis, but these patients tend to produce more hypokalemia and metabolic alkalosis, that too very early in the course of the disease. The reason is very simple. That's because of extremely high levels of ACTH. Remember, if you ask among all the conditions, endogenous cause or even exogenous cause of Cushing's, whatever cause, highest level of glucocorticoids you will see in this ectopic cause only. And among all the endogenous causes, highest levels of ACTH compared to the pituitary you will be seeing in ectopic cause only. Such high amounts of ACTH will be produced in ectopic conditions causing Cushing syndrome. So this extremely high amounts of ACTH will obviously act on the adrenal gland, will produce excessive cortisol, too much cortisol, and this is also going to produce too much DHAS, because DHAS is also dependent on the ACTH only, and they can even produce excessive 11-deoxycortisone. Clear? We all know that this up to 11-deoxycortisosterone ACTH can stimulate. Beyond that, to produce aldosterone, you need this aldosterone synthase enzyme. So it cannot produce aldosterone, but still it can produce a substantial amount of 11-DOC, which itself possesses a good mineralocorticoid activity. And this 11-DOC will act on the mineralocorticoid receptor to produce hypokalemia and metabolic alkalosis. This is one mechanism, first mechanism. Second mechanism, because of extremely high amounts of cortisol, which can spill over. Obviously, this cortisol should work on the glucocorticoid receptor only. But because this glucocorticoid receptors cannot take up this much amount of cortisol, it will spill, and normally itself your cortisol will be very high in the body. I already told you, this high cortisol is usually shielded from the mineralocorticoid receptor by a hormone called 11-beta-HSD2. I told you this already. So which will convert this cortisol to cortisone, especially in mineralocorticoid responsive tissues like colon, sweat glands, and kidneys, so which are typical mineralocorticoid responsive organs. So these organs are shielded from the effects of cortisol by this 11-beta-HSD2 enzyme. But in conditions like this ectopic ACTH production, there will be too much cortisol that can spill over and can now work on the mineralocorticoid receptor, because now the 11-beta-HSD2 also cannot handle this much amount of cortisol, and it will be fully saturated and will spill over, and it will work on the mineralocorticoid receptors to produce hypokalemia and metabolic alkalosis, which means any Cushing syndrome, if they produce significantly high amounts of cortisol, they can produce hypokalemia and metabolic alkalosis. But this is very, very important with regards to the ectopic ACTH production causing Cushing syndrome. Clear? Very, very important point. At the same time, what will be the results of this dexamethasone suppression test? So when you do a low-dose dexamethasone suppression test, there will be no change in the cortisol, which means cortisol levels cannot be suppressed with low-dose dexamethasone. When you do a high-dose dexamethasone suppression test, once again there will be no change. That's why this is a very crucial point, because among the ACTH dependent causes, you have only two causes, isn't it? One is this pituitary-related Cushing syndrome and ectopic ACTH producing Cushing syndrome. This HDST is one standard test that is used to differentiate between a Cushing's disease, that is pituitary adenoma causing Cushing syndrome, and ectopic ACTH causing Cushing syndrome, because only pituitary adenoma or Cushing's disease or pituitary related causes will respond to this high-dose dexamethasone, whereas this ectopic ACTH producing Cushing syndrome, these cancers will not respond to high-dose dexamethasone suppression test. That's a very, very important point. Clear? So now let us move on to the ACTH independent causes. ACTH independent causes can have problems in the adrenal glands, as I told you before, or they can have problems in the receptors, which I'll be discussing in detail. Receptors as well. Whenever you tell ACTH independent, means they'll be having high cortisol due to some adrenal defect, some adrenal problem, some tumor in the adrenal gland or receptor defect in the adrenal gland producing high cortisol autonomously. And obviously, since the hypothalamic and pituitary axis within them is intact, so they will be having low ACTH. Because there is low ACTH, there will be no hyperpigmentation. As I already told you, your ACTH dependent causes will have hyperpigmentation, whereas your ACTH independent causes will not have hyperpigmentation, but they will have Cushing syndrome. So what are the adrenal causes? Adrenal causes can be divided into an adrenal adenoma and an adrenal carcinoma. What is the relative contribution of the adrenal causes to the Cushing syndrome? Approximately 5 to 10%, small number, but still important. And once again, your females will be affected more than the males. Clear? But whereas this ectopic causes, I didn't tell you this number, 15 to 25% is the contribution, not so high, but still substantial amount. 15 to 25% of the endogenous Cushing syndrome will be due to ectopic ACTH production, where there will be no sex predilection. And this is a very important point. And female-male ratio here is 1:1, equal. Once again, in adrenals, as I told you, the female preponderance will be there. Females will be relatively more affected compared to that of the males. So we have two causes, adenoma and a carcinoma. Adenomas generally tend to be small and homogeneous, and in non-contrast CT, they tend to have less than 10 Hounsfield units density, whereas carcinoma tends to be large, heterogeneous. They may have areas of hemorrhage and necrosis, and in CT, they generally tend to show more than 10 Hounsfield units density with irregular borders usually, and there might be an invasion also. Usually in adenoma, there will be low DHAS, whereas in carcinoma, they might be having a high DHAS. Not only high DHAS, they might even have a production of unusual metabolites, like they might have increased 17-hydroxyprogesterone and many other metabolites. Because carcinoma means all the steroidogenic pathways will be activated in the carcinoma, so they will be producing excessive DHAS, they will be producing excessive 17-hydroxyprogesterone, they will be producing excessive cortisol, they might be even producing excessive deoxycorticosterone also. And this excessive DHAS can produce virilization. And that is why presence of virilization is an important sign of malignancy, adrenal cancer. I have discussed about that in the hyperandrogenism section itself. Very rarely, this excessive DHAS that is produced by this ectopic tumors can also produce virilization. Ectopic cancers can also produce virilization, which means virilization is a sign of a cancer usually. So that is why in adult, especially in adolescent and early adults, this virilization is a very, very important sign. So often underlying cancer. So you have to be evaluating very, very carefully. DSDs are actually very rare, and these disorders are quite common. So that is why you have to think about cancers as a first point whenever you think about adolescent or an adult getting virilized, especially if it's a female, because these are female predominant diseases in the first place. So why DHAS is low in a patient who's having a adenoma, cortisol producing adenoma? It's very simple. As I already told you, in ACTH independent causes, adrenal causes producing Cushing syndrome, there will be low ACTH. Whenever you have a low ACTH, you will have a low DHAS only, because zona reticularis is also under the control of this ACTH only. Whenever you have a low ACTH, you're going to have a low DHAS production only. So that is the reason why simple adenomas will have low DHAS, whereas carcinomas may have a high DHAS. Fine. And many adenomas can be a result of some somatic defects also. Many somatic defects are coming, and one of the important examples that they will be asking in your exam regarding the somatic defects is the Beckwith-Wiedemann syndrome, where you will be having elevated levels of IGF-2, and this is the very basic pathophysiology happening in Beckwith-Wiedemann syndrome, which is the reason for many problems in Beckwith-Wiedemann syndrome also. This also can stimulate the adrenal cortex, and especially zona fasciculata produce excessive cortisol and adrenal adenoma. And the P53 related mutations have also been described, but that is not important with the current context. And what will be the features? Usually they will be a little slow if it's an adenoma, or rapid if it's a carcinoma. And carcinomas generally tend to have this metabolic alkalosis and hypokalemia, because they'll be producing more of deoxycortisone also. And adenomas generally not have this hypokalemia and metabolic alkalosis unless and until they produce too much amount of cortisol. So anyways, the course is a little variable here, and usually it affects young adults. If it's an adenoma, if it's a carcinoma, it will be affecting children usually. Children are more affected with adrenal carcinoma compared to that of adults. But adrenal adenoma is very common in young adults. Fine. What will be the response to dexamethasone suppression test? When you use a low-dose dexamethasone suppression test, LDST, there won't be any change. Obviously, any Cushing, endogenous Cushing, if you give a dexamethasone suppression test, they will not respond to this dexamethasone suppression. That's a very important point. And high-dose dexamethasone suppression test, once again, there will be no change in the cortisol, which means there won't be any cortisol suppression. They are going to behave similar to that of ectopic ACTH producing Cushing syndrome. But this can be easily identified through ACTH levels itself, because ectopic causes will have elevated ACTH, and this adrenal causes will have a suppressed ACTH. That's very important. So anyways, these are the LDST findings. And we are moving on to the receptor-based causes. These are coming up pretty nicely in the last 1 to 2 decades, where the nodular hyperplasias causing Cushing's have been increasingly discovered in the last 1 or 2 decades. So receptor level problems can be due to any receptor problem. So let us first see the problems in these receptors and what are the basic function of these receptors. We know that ACTH is going to work on the melanocortin 2 receptor, which itself is a G-stimulatory type of receptor, which means they're going to activate adenylate cyclase and they're going to produce cyclic AMP. I believe this cyclic AMP can be degraded to cyclic GMP by phosphodiesterase enzyme. This cyclic AMP is further going to activate this protein kinase A, and this protein kinase A activation is the main reason for excessive cortisol production, increased cortisol production in the zona fasciculata cell. Not only the MC2 receptor plays a role, a little role is played by our V1 receptor, our serotonin receptor, that is 5-HT4 receptor, then our beta adrenergic receptor, then our LHCG receptor, then we have GIP, gastric inhibitory peptide receptor also. All these receptors play a little role in production of cortisol under physiological circumstances. But whenever there are mutations, pathologic circumstances, they can produce too much of cortisol also. So this is the basic arrangement that you have to know. Now with this basic understanding, let us see what will be the receptor level problems. Receptor level problems can be divided into 2 groups of disorders. One, those that cause micronodular hyperplasia, where the nodule size in the adrenal glands will be less than or equal to 4 mm, or it could be a macronodular hyperplasia where it can be picked up by the CT itself and they'll be having more than 5 mm size nodules. This micronodular hyperplasia is also referred as something called a PPNAD. That's called a primary pigmented nodular adrenal disease or primary pigmented nodular adrenal hyperplasia. Remember, the name pigmented may or may not be there, but nodularity will definitely be there. So what are the conditions that will produce this PPNAD? There are many conditions. So one, it can happen either sporadically or it can happen through a complex called a Carnase complex, which I have discussed already in the men syndrome and the MCOMS section. So sporadic contributes to 50% and Carnase complex will contribute to 50%. Remember, the most common genetic mutation that produces Carnase complex and this primary pigmented nodular adrenal disease is PRKR1 alpha, which is nothing but a protein kinase A subunit. So you can understand now through this diagram, whenever you have this increased function of protein kinase A due to this problem in the mutations in the PRKR1 alpha, you might have excessive protein kinase A activity. Because of that, you might have a excessive cortisol. It's understandable. That's what happens in Carnase complex. So what are the genes that are related to this sporadic as well as Carnase complex and related receptor level hypercortisolism? One is, obviously we have discovered, that is PRKR1 alpha, which is present in chromosome number 17. Whenever the PRKR1 alpha, whether it is in Carnase complex or in sporadic cases, if it is involved or mutated, it will result in a very early disease and in fact a very severe disease, and they will have skin problems also. You can go and see the kinase complex I had described extensively in the video. And next is the phosphodiesterase 11A gene, which is present on chromosome number 2. Involvement of this will result in a non-pigmented nodule. That's why I told you that pigmentation may or may not be there. But even though it's called a PPNAD, it's a non-pigmented nodule. Number 3, you have phosphodiesterase 8B, which generally tends to produce only mild disease, and they may or may not produce hypertension. Number 4, you can have problems in the MYH8 gene also, present chromosome number 17, where it will produce Cushing syndrome along with arthrogryposis and myxoma. You can understand the problems with phosphodiesterase also. Suppose if you have problems in this phosphodiesterase, your cyclic AMP activity will be high. Because of that, protein kinase A activity will be high. Because of that, you might produce high cortisol. So these are the receptor level and messenger level defects. So what are the peculiar features of this PPNAD? PPNAD itself has some peculiar features, and it might be different from your typical Cushing syndrome. In the sense, it can be cyclical, which means they can only produce bursts of cortisol. In the meanwhile, in between, they may have months of normal cortisol levels. So, which is going to give a diagnostic nightmare to many physicians, because they might have a normal cortisol at one point, they might have elevated cortisol at one point. This needs high degree of suspicion and very difficult to diagnose. And they have many atypical features, like the patients may be thin and the patients may have normal growth. So why this normal growth is an atypical feature? Many of this receptor level Cushing syndrome will be presenting in childhood only. Whenever you expect a childhood Cushing's, you generally tend to have a suppressed growth, because Cushing syndrome and high cortisol is something that is going to have a growth suppressing activity. I already told you glucocorticoids have a very powerful growth suppressing activity. It can act at the level of growth hormone release, it can stop the growth hormone release, it can act on the level of growth hormone action, it can act on even on the level of IGF-1 action, which is a somatomedin. So cortisol can act at multiple levels to suppress the growth in the body. So anyways, so these patients may have a normal growth, probably due to intermittent cortisol excess. Maybe they have intermittent normal cortisol levels also. That time they may permit the growth due to growth hormone related pathways. So they might have a normal growth, which is a very atypical thing in childhood Cushing's. And these patients tend to have a high risk of developing osteoporosis compared to their peers. That's a very important point. And at the same time, the low-dose dexamethasone suppression test, like all other Cushing's, endogenous Cushing's, they will not have any suppression of cortisol. But when you give a high-dose dexamethasone suppression test, they may show a paradoxical increase in cortisol rather than a suppression of cortisol. This is a very, very important point as far as exams are concerned. Paradoxical increase with cortisol may be seen. The reason we don't know really why it happens, but still, paradoxical increase in cortisol is seen with many of the patients with PPNAD. That's a very, very crucial point. They may have normal cortisol, no response also, but many patients tend to have a paradoxical increased cortisol in response to high-dose dexamethasone suppression test. Macronodular hyperplasia. I told you the nodules here will be 5 mm or more. And the defects can be at many receptors. For example, it could be a McCune-Albright syndrome. McCune-Albright syndrome. Remember, McCune-Albright syndrome is a triad of Kaplan-Meier macules, then you have precocious puberty, and you have this fibrous dysplasia of many long bones. So McCune-Albright syndrome is a syndrome due to GNAS1 gene defect, which means it's going to produce gain of function mutations of GNAS1 gene, and it's going to produce excessive function of this GS-alpha protein. Obviously, you can understand now this excessive action of GS-alpha protein. Here it is the G-stimulatory protein here. So it's going to produce more and more cyclic AMP, more and more protein kinase A, and more cortisol. And that is the reason why you're going to result in this Cushing syndrome due to macronodular hyperplasia. And they can also have other hormone excess. That's the reason why they cause that precocious puberty as well. So we're not going to discuss about that right now. We have already discussed in detail. Apart from that, there could be mutations of other genes like ARMC5. This is called armadillo repeat region. So that can have mutation. Or they can have other receptor mutations like vasopressin 1B receptor mutations, which I told you that's important for cortisol to an extent under physiological conditions. But pathologically, if they're having some gain of function mutation, they might have high cortisol output from the zona fasciculata. V1B receptor, beta adrenergic receptors, serotonin receptors, LHCG receptors, gastric empty peptide receptors. So all these receptors also can have some defect. Because of that, they might produce high cortisol. So these are the reasons for macronodular adrenal hyperplasia causing Cushing's. And what will be the dexamethasone suppression test? When you do a low dose dexamethasone suppression test, there will be no stimulation, no suppression of cortisol. And when you do a high dose dexamethasone suppression test, again there will be no suppression, which means they are going to behave like other adrenal problems only. Only in PPNAD you will be usually encountering a paradoxical elevation of cortisol with high dose dexamethasone suppression only. What is the percentage of Cushing syndrome that will be caused as a result of this receptor level problems? Less than 2%. Some books tell you 2 to 3%, but in general less than 2% case of the endogenous Cushing syndrome are due to this receptor level problems. Remember, endogenous Cushing's most common cause is Cushing's disease, that is pituitary adenoma causing Cushing syndrome. So let us summarize the facts which I have studied till now, because it's been a long journey. Let us summarize the facts and we'll move on to the clinical features of Cushing syndrome in some time. The most important thing is the understanding of this low dose dexamethasone suppression test versus high dose dexamethasone suppression test. First, let us see how will you evaluate basically. Usually this low dose dexamethasone suppression test is given for diagnosing Cushing's. Because any condition if you take, whatever I told you, I'm not going to show it again, any condition you take, they are going to have non-suppressible cortisol. They are going to have high cortisol which cannot be suppressed with dexamethasone. Which means if you have suppressible cortisol, which means cortisol level drops considerably with low dose dexamethasone, it is a normal patient. It's not a Cushing syndrome patient. Only if the cortisol levels does not drop or there is no change in the cortisol levels, so non-suppressible cortisol, then only you will diagnose a Cushing syndrome, which means low dose dexamethasone suppression test is used for diagnosis of Cushing syndrome. Once you have made a diagnosis of Cushing syndrome, now you have to see the serum ACTH levels. So to see whether it's ACTH dependent or independent, if ACTH is suppressed, we go towards ACTH independent causes. If ACTH is high, we are going to think about ACTH dependent Cushing's. All of them have their own sub-causes, isn't it? Like ACTH dependent causes can be either a pituitary cause, very commonly it's a Cushing's disease, which means an adenoma, or it could be an ectopic cancer as well. Both can produce high ACTH and high cortisol. ACTH independent causes usually will be adrenal level causes or receptor level causes. Clear? But receptor also can be put under adrenal cause, but anyways, just to make sure that you understand better, I'm putting as a separate cause. Now to differentiate between ACTH and ectopic, you can use a high dose dexamethasone suppression test. So where if you have no change in the cortisol, it usually go towards ectopic cause, which means there is no suppression of cortisol, and ACTH means it's an ectopic ACTH causing Cushing syndrome. Or if there is a appreciable suppression of ACTH and cortisol in response to high dose dexamethasone, then it goes towards a pituitary cause. Clear? So high dose dexamethasone is a localizing test. That's what I'm trying to tell. It's not a diagnostic test. Clear? So that is the reason why this order in endocrine is very, very important. First you do a low dose, then only you go for a high dose. Because low dose is for diagnosing Cushing syndrome, high dose is for localizing Cushing syndrome, especially pituitary versus ectopic cause. Understand this. Suppose if you have done a high dose test before, you have accidentally done a high dose test before, what will happen? And the cortisol levels are dropping. With high dose dexamethasone, the cortisol levels are suppressed. Whether this is a normal patient who can suppress cortisol in response to an exogenous steroid, or is it a pituitary cause causing Cushing's disease? How will you understand? So that is the reason it will lead to a very big diagnostic confusion. That is why don't do HDST first, always do a LDST first, confirm it's a Cushing. Then for localizing in ACTH dependent conditions, you can use HDST. Is there any role for HDST here? Remember, you can do an HDST, yes, in adrenal causes also. If there is no change, you can think about a proper adrenal cause, like an adrenal adenoma or a carcinoma, or it could be a macronodular hyperplasia also. Both will not have any change in cortisol levels, which means cortisol levels will not be suppressible with high dose dexamethasone also. But if you have a paradoxical increase in cortisol, you can think about a PPNAD, micronodular adrenal hyperplasia, that is primary pigmented nodular adrenal disease like Carney's complex and all. So once again, one final time I'm saying that low-dose dexamethasone suppression test is a diagnostic test, whereas high-dose dexamethasone suppression test is a localizing test for Cushing syndrome. Now let us move on to the clinical features of Cushing syndrome. For our good understanding, I'm going to split the clinical features of Cushing syndrome into those features that are relatively non-specific with respect to Cushing syndrome, and those features which are relatively specific for Cushing syndrome, and those features which are very specific for Cushing syndrome. And there are some features which can be associated with Cushing syndrome which may not give a good clue. What are the non-specific features? First one is the weight gain. Weight gain is supposed to be the most common clinical feature of Cushing syndrome, but even though it is very, very non-specific. You cannot diagnose a Cushing syndrome based on weight gain alone. Second one is the hypertension. This hypertension is a secondary hypertension. I told you most of the conditions, hypertension in Cushing syndrome is due to the spilling effect of cortisol that's saturating the 11-beta-HSD working on the mineralocorticoid receptors to cause hypertension. And it can also be due to excessive ACTH producing excessive deoxycortisone also. Fine. And this hypertension is supposed to be the second most common clinical feature of Cushing syndrome. And third one, they can result in glucose intolerance, which can produce hyperglycemia, and they can progress to frank diabetes mellitus also. Cushing is a very, very important endocrine cause of diabetes mellitus. Diabetes may be due to many pathological mechanisms, like cortisol excess itself can produce increased glucose because glucocorticoids, isn't it? So they are going to produce glucose. And they can produce central obesity that can also result in insulin resistance and hyperglycemia. So they have multiple mechanisms. And they can also result in oligomenorrhea, amenorrhea, and they can result in loss of libido also. This loss of libido is usually associated with low DHEAS. So this is very classical of adrenal adenoma. All these things are very common in females. Obviously, you cannot tell this in males. In females, these are very common, especially in adrenal adenoma. They'll have a low ACTH. Because of low ACTH, they might have a low DHEAS. Because of the same, they might result in loss of libido. And this oligoamenorrhea is usually a hyperandrogenic feature. So usually this is due to ACTH dependent causes. In ACTH dependent causes, there will be high ACTH. High ACTH means they will be producing high DHEAS. Because of high DHEAS, they have a state of hyperandrogenism. Because of the same, they might result in oligo and amenorrhea. Similarly, they may have a acne and hirsutism. That is also a sign of hyperandrogenism and it is usually due to ACTH dependent causes, due to high ACTH, producing high DHEAS. They can produce peptic ulcer disease, which is very fairly common in the community. It does not tell you it's a Cushing syndrome because cortisol and any glucocorticoid can produce increased acid production and peptic ulcer. And they can produce osteoporosis, which is again very relevant in the community, very prevalent in the community, very, very common in the community, which you cannot tell that patients having Cushing syndrome because they have osteoporosis. What are the relatively specific clinical features that will tell you that the patient is having Cushing syndrome? Number one are the rounded faces, that moon-like face, round obesity in the face, that is relatively specific for Cushing syndrome. And number two, this dorsocervical fat pads. Best example is buffalo hump, where they have a, like fat redistribution. This dorsocervical fat pads and centripetal obesity, which I'll be describing in some time, are all due to this redistribution of fat that is an effect of high cortisol. High cortisol peculiarly redistributes fats from the peripheries towards the center. For that, they can result in this buffalo hump and especially the supraclavicular fat pad. This is a dorsocervical fat pad. Especially the supraclavicular fat pad is very, very specific for Cushing syndrome. Supraclavicular fat pad, this fullness of the supraclavicular fossa. And number three, which is relatively specific, is centripetal obesity. What do you mean by centripetal obesity? Once again, they will be very obese in the central regions, like the abdomen will be very big, their supraclavicular fat pads and all will be full, and they will be having buffalo hump, but extremities will be very thin. That is because of the redistribution of fat by excess cortisol. That's a very peculiar effect. Because of the central obesity, they can develop insulin-resistant diabetes, which I told you already. But the centripetal obesity is a very important word, where they will be having paucity of fat in the extremities, but they will be having so much of fat in the central areas. And there are very specific clinical features of Cushing syndrome, like for example, spontaneous bruising. The spontaneous bruising, we know it is due to increased capillary fragility. That is the reason why they develop this spontaneous bruising, and this can happen even with inhaled corticosteroids. We have seen in a lot of bronchial asthma patients who are using high-dose inhaled corticosteroids. The patients may develop wide purple striae, which is very specific for Cushing syndrome patients. You know what do you mean by a striae? Striae means stretch marks, wide and purple. Wide means by definition it should be at least more than 1 centimeter wide, and why it is purple? Because of the capillary fragility, because sudden stretching will break this already fragile capillaries where they are going to leak their blood, and once they leak their blood, that will be digested, resulting in purplish discoloration. That's why you get this white purple striae. And proximal myopathy, very important. This is called steroid-induced myopathy, the details of which we'll be discussing more in the rheumatology section, especially in the myositis part. They might result in hypokalemia and metabolic alkalosis. Most of the times in Cushing syndrome, this hypokalemia and metabolic alkalosis is due to the spilling effect of cortisol, which I told you already. Coupled with that, in ectopic ACTH producing conditions, they might result in even excessive production of DOC that also can result in hypokalemia and metabolic alkalosis. These are some of the very specific clinical features with regards to Cushing syndrome. And there are some other extra features of Cushing syndrome are there, mostly the CNS manifestations like insomnia, psychosis. We have seen even after a single shot of dexamethasone in ICU, they have gone for steroid-induced psychosis. It's a very important point. And depression. Depression is very important because depression can cause physiologic hypercortisolism, and hypercortisolism can cause depression, which is actually pathologic. So in both ways, it can happen. And the patients may have reduced cognitive function. They can develop hirsutism, acne, and features of hyperandrogenism, which I have already mentioned. And patients may develop hyperpigmentation, and this happens only in those individuals who are having ACTH-dependent Cushing syndrome. Because of excess ACTH, they might develop hyperpigmentation. Because ACTH doesn't come alone, it comes along with MSH from the pituitary, so that might cause melanocyte stimulation and hyperpigmentation. And hyperpigmentation usually you will be seeing in the sun-exposed as well as non-sun-exposed areas, but when you see in the non-sun-exposed areas, that is relatively more specific to ACTH excess and MSH excess. Like for example, if you see in the pressure areas, like in the areas where you have innerwear, like in the bra tightening areas and in the underwear areas, those areas, if you see, it is more specific in the genital regions, in nail beds, especially in the foot, in the gums. These are very specific areas for ACTH excess causing hyperpigmentation, the more details of which we'll be seeing in the next chapter in adrenal insufficiency. Apart from that, they may have multitude of hematological effects which are not so specific for Cushing's, but still you might get. Like for example, neutrophilia, lymphopenia, and eosinopenia. As I already told you, this neutrophilia is usually due to demargination of the neutrophils and not due to excessive production of neutrophils from the bone marrow. That's a very important point. Apart from that, they might have erythrocytosis and increased platelet production also. And that is thought to be the reason for this facial plethora that is seen in many of these patients. Vasodilation coupled with erythrocytosis may result in this facial plethora. And there is increased susceptibility to developing infections, especially local infections of the skin like candidiasis, fungal skin infections, very common. Because steroid induces a state of immunosuppression, we know that. And these patients may develop cataract as well, especially the posterior subcapsular variety of cataract, which is typical of a steroid-induced cataract. So we have seen a lot of clinical features, but what is the most common cause of death in these individuals? It's always the cardiovascular cause, because they heighten the CV risk, and many of these patients will die of myocardial infarction. Even subclinical Cushing's also may result in increased risk of developing myocardial infarction and death, and that is a very important point to know. Most common cause of death in these patients. Let us see some of the images. This is a classical patient who presented to us with Cushing's disease, which means a pituitary adenoma Clear? So initially you can see a typical moon-like face, a round face with dorsocervical fat pads and buffalo hump and a white purple stripe. So once the tumor was resected, this is at 3 months, you can see there is obvious decrease in the size of the face and decrease in the buffalo hump. The striae starts to disappear. And at 6 to 12 months after treatment, you can see the patient regained her normal looks in comparison to the old photos, and there is no dorsocervical fat pad and buffalo hump, and absolutely there is no striae. So all these things are completely reversed because of the treatment, that is transsphenoidal surgery in this particular patient. Now let us move on to the workup of Cushing syndrome. Before going into the details of workup of Cushing syndrome, it's very important to understand certain important points. Like you need to know about the diurnal variation, which we already discussed, but let us discuss in a little bit more detail now. And we need to know about the influence of the cortisol binding globulin, CBG, on the total serum cortisol. And we also have to know about the dexamethasone suppression test. These are 3 things that we commonly use for diagnosing Cushing syndrome. So these 3 things has to be in your fingertips. So what is the diurnal variation? We know that cortisol is going to be at peak along with ACTH at around 8 AM. But this 8 AM is often a hybrid thing. I don't believe in this 8 AM because nowadays a lot of people are having different timings in the sleep-wake pattern. So you should tell, usually the cortisol will be at peak 1 hour after waking up. Usually immediately after waking up, or at least 1 hour after waking up, your cortisol will be at peak and ACTH also will be at peak. So why this point is important? Because you will be encountering a lot of shift workers where they will be having a altered sleep-wake pattern. So their diurnal rhythm may be working completely differently. So because they sleep in the morning and work in the night. So you have to be very careful with the shift workers. And people who are binge eaters, because binge eating will increase ACTH and increase cortisol. You have to be careful about that. That can change the diurnal rhythm as well as that can change the entire cortisol rhythm itself. And you have to be wary of this jet lag as well, because people who are traveling from different time zones may not have a good diurnal rhythm. I mean, the sense like their diurnal rhythm will be fit into their own time zone, but it will take at least 15 to 20 days for the hypothalamus to get rid of the confusion and come back to the current time zone. So you have, whenever a patient is coming from a different time zone, make sure you give a time of 15 to 20 days before checking for the cortisol. And where will be the cortisol low? What will be the time when the cortisol and ACTH will be at its rock bottom, will be at its low? Usually at around 11 PM to 12 AM. This is the time where cortisol and ACTH will be at its low. And this is obviously the best timing for diagnosing serum cortisol if you are suspecting a Cushing syndrome. Remember, 11 PM to 12 AM, usually your cortisol must be low. But if you see a high cortisol at this time, so this is usually suggestive of a Cushing syndrome, because you are proving that the patient is having this blunting of diurnal rhythm, which means there is persistent elevation in the cortisol even when the cortisol should be at its low. So that usually tells you probably the patient is suffering from a Cushing syndrome. But 8 AM cortisol, we usually don't do, because at 8 AM usually the cortisol is high, so it might not make your diagnosis of Cushing syndrome. Usually 8 AM cortisol is used for diagnosing adrenal insufficiency rather than Cushing syndrome. But where you can use 8 AM serum cortisol, there is still some use whenever you are suspecting an exogenous Cushing syndrome. You can use 8 AM serum cortisol, because whenever you have an exogenous Cushing syndrome, which means the patient will have clinical features of Cushing syndrome, but the patient's 8 AM serum cortisol, which actually should be high, will be very low. 8 AM serum cortisol will be low. Whenever the 8 AM serum cortisol is low and the patient is having Cushing's features, so it is usually suggestive of a exogenous steroid use. Remember, exogenous steroid use is very easy to pick up because patient itself will give you a clear history of usage of this exogenous steroids. But there are some areas where you may not be able to diagnose these exogenous steroids, especially when the patient is not able to know whether he or she is taking exogenous steroids, especially when a child is getting a health drink or some cosmetic items when you are using on the topical, where you might have the steroids when you're applying inflamed area, it might get absorbed. So in those conditions and all, it's difficult to pick up this exogenous steroid use. So in that setting, this 8 AM serum cortisol may be used in Cushing syndrome. But apart from that, any endogenous Cushing's, if you suspect, 8 AM serum cortisol should not be done. It's better to do late night serum cortisol or a late evening salivary cortisol. Second point that you have to be careful about is the effect of cortisol binding globulin on the total serum cortisol levels. For example, we know cortisol circulates in free form as well as in the bound form. In the bound form, almost 90% of the cortisol is going to be bound with the cortisol binding globulin, and only 10% is bound with albumin and another insignificant protein called A1 glycoprotein. So CBG is the main player here. It's going to completely alter the total serum cortisol, because whenever you order for a serum cortisol test, you are going to get a total serum cortisol only. So the total serum cortisol can be falsely high or falsely low depending on the CBG levels, which can be falsely high or falsely low. For example, conditions that increase the CBG like pregnancy and exposure to estrogen in the form of oral contraceptive pills or hormone replacement therapy may falsely increase the total serum cortisol by increasing the cortisol binding globulin. Similarly, conditions that reduce the cortisol binding globulin like nephrotic syndrome and cirrhosis, where there will be low CBG. So you might have a falsely low total serum cortisol because, obviously the cortisol binding globulin will be less in these scenarios. Why this point is important? Because whenever you are using a test that is going to use this total serum cortisol, that might be a possible area where you might be very careful with. For example, what is the test that uses this total serum cortisol? Obviously, the serum cortisol test itself is going to use the total serum cortisol. And when you are using a dexamethasone suppression test, especially the low dose dexamethasone suppression test for diagnosing Cushing syndrome, you have to be very careful, because after dexamethasone suppression, you are going to see the serum cortisol only. And the serum cortisol may be erroneously high if the CBG values are high. So in that setting, you might falsely diagnose the patient is suffering from Cushing syndrome. This is very true. Many times I have seen in my OPD itself, where whenever a patient is coming with obesity, especially a young female coming with obesity, they might have acanthosis nigricans and all. But these patients, my residents and interns will suspect as Cushing syndrome. They will send for a serum cortisol, and the serum cortisol comes up very high. And they will immediately bring to me telling that it's a probable case of Cushing's. And even some smart interns, even they will do ACTH and they will come to that extent. But they would have failed to ask a very, very simple history, that patient might be having history of using oral contraceptive pills, because this obesity could have resulted in PCOS, and local practitioner would have prescribed OCP for the same. So this OCP would have increased the cortisol binding globulin, and that is the reason why you are getting this falsely high values of serum cortisol. This is true especially when you are using a dexamethasone suppression test also. So when they bring to me, what I will be telling is, I will be first asking the history of OCP. Once there is a history of OCP, I will be asking my intern to do the 24-hour urinary free cortisol. Once they do this 24-hour urinary free cortisol, it will be completely normal. Which means here this free cortisol is not affected by the cortisol binding globulin. That is why whenever you have this confounding factors in your clinical setting, it's better to do a assay that does not use the total serum cortisol, which means you should use an assay which is independent of the cortisol binding globulin effect. For example, what are the assays that are independent of the CBG effect? One is the 24-hour urinary free cortisol. It is not dependent on the cortisol binding globulin. Second is the late evening salivary cortisol. This is coming as a pretty important and decent screening test right now. Late evening salivary cortisol, which is again independent of the cortisol binding globulin effect and total serum cortisol.